morning, Dr. Gada. Thank you so much for joining me to discuss optimization of transcatheter aortic valve replacement. Your manuscript is just packed full of excellent information. So thank you.
Thanks for having me, Dr. Grubb. It's a pleasure to be with you today.
So in your manuscript, you kind of went through all of the ways that we are optimizing implants. When you and I started this, almost a decade ago, we were happy when the valve stayed in the annulus. Where are we now, and what is important not only to the heart teams, but to the patients?
Yeah, I think it all goes towards trying to give our patients the best possible outcomes post-procedurally from what is a minimally invasive approach to replace aortic valves. And at that point, you're really dealing with a patient population that was doing well with surgery for the most part. If we're talking about the low and intermediate risk cohorts that we now have commercial indication to treat with TAVR. And so really our outcomes have to be perfected and made just simply excellent. Relative to surgery, we have to be comparable or even beat surgery with certain metrics. And so that's kind of the foundation of what we're going to talk about today. And there's just so much going on in our field to perfect transcatheter heart valve outcomes, not just from the technological development, but how we plan and execute our procedures.
Well, your paper goes through so much, so I'm going to try to just kind of pick apart the different sections. But how did you get this idea to be a champion of this cusp overlap technique? You were an early adopter. In the manuscript, I think it says 2015 you started doing this. You finally convinced me by 2019, so I was late to the game.
I don't think you were late to the game, but I feel like obviously, we needed to simplify the deployment of these transcatheter heart valves to the point where they were predictable, where we were going to achieve an implantation depth that would be reflective of what our true implantation depth was on echocardiography or if we did CTs afterwards. And we knew that fluoroscopy was filled with figments and that if you didn't understand your two-dimensional fluoroscopic projection, it could be quite misleading and really not guide you as to where you were actually truly deploying the valve. And so really that was the foundation of this. You and I both trained at balloon expandable institutions. And so really 100% or near 100% of the valves were done with balloon expandable platforms. And what that meant for us was basically an ability to deploy in certain gantry views that may not have applied to the self-expanding prosthesis. And I remember my early experiences with the self-expanding valve that we were just not really sure of where that valve was being deployed. And because of that, our rates of conduction disturbances, meriting pacemakers was much higher than it should have been, especially when compared to surgery or the balloon expandable platform. And so those were things that were pretty worrisome, I felt. And so that's the reason why Cusp Overlap was really adopted by us pretty early. We were proctored by a European proctor that really thought that ariocaudal was the best angle to use when implanting a procedure, when implanting a self-expanding valve. And when we really dissected the CT, there was more to it than that. It was really elongating the left ventricular outflow tract, putting the membranous septum smack dab in the center of the screen, and creating a two-dimensional view on fluoroscopy that was reflective of where exactly we were landing the valve, similar to a long axis of a transesophageal echocardiogram or a parasternal long axis or an apical three-chamber on a transthoracic. And so that's really what the cusp overlap view emulates. And then all the technical modifications we'll discuss kind of came after that.
And, from the way I'm hearing it, is this not really applicable to just one valve? We hear about it a lot with the Medtronic platform, but should we be doing this for all TAVRs?
We routinely do it for all of our TAVRs. We feel like the anatomic discrimination that we get on screen for all of our transcatheter heart valve deployments, like we're never doubting where exactly we're going to be positioning and landing the valve. And I think that's one of the hallmarks of the view. Definitely the technical modifications are a little bit different across platforms, but at least the starting view and what we execute the deployment in is going to be remarkably consistent.
And so for a team that's new to a self-expanding valve and is transitioning from a balloon expandable platform to a self-expanding platform, give me the quick and dirty, how do you teach this? I mean, your manuscript goes through the CT scan, the thought process, but give me the short version.
Yep. Short version is as follows. We're going to start out in a view that isolates the non-coronary cusp, overlaps the right and left cusps. That can be diagrammed on CT scan quite easily. Most of your self-expanding reps, if you are transitioning over to using that platform, are going to be quite adept at reconstructing that view for you using 3Mencio and kind of taking you through it if you're interested in doing that. Once we start out in that view, we're really going to foster a top-down deployment. And so what that means is that we're going to put the marker band of the self-expanding platform around mid-pigtail, and we're going to aim for a top-down approach when we deploy the valve. That's going to minimize our interaction with the conduction system. Then we're just going to do 2 checks on aortography, one in the cusp overlap view to make sure that we like the depth on the non-coronary cusp side. Then we'll swing LAO to make sure that we've captured the left coronary cusp, give us more of an idea of where the delivery catheter lies in the ascending aorta, and then we just simply go for TAV release from there. So it can be a very quick, efficient procedure where you know exactly where you're landing the valve.
And you've advocated for these really, really high implants, 3 millimeters or even 0 millimeters. I know that when we started using the CoreValve Classic, there was this huge fear of pop outs. You're going to let go of release the valve, and it's going to fly into the ascending aorta. What are you seeing with this technique?
So I will tell you that, obviously the cusp overlap technique is geared to kind of help you deploy a valve and know exactly where you're deploying it. And so I think most of our deployments here are going to be around 3 millimeters, and that's kind of what our usual TAVR deployment is. We'll very rarely shoot for a 0. Maybe we've got advanced conduction disturbance and a less calcified valve, and we're not worried about needing post-dilation. Then maybe in those cases, we'll aim a little shallower. But that's the great thing about the technique and the view, is that it's going to give you that level of discrimination such that you're able to really deploy and implant with sub-millimeter precision. And that's really what the view is all about. So I agree with you. I don't want to pop out. I think that those are horrible. And obviously our pop out rate is quite low. Otherwise this technique wouldn't have been kind of, a spread across the world. But I will say that what this view in technique is intended to do is really truly show you where you're landing the valve.
Yeah. And, one of the other things that I've noticed is the paravalvular leak rate, and you mentioned it in your paper as well. Now, why would landing a valve higher result in less PVL?
It's a good question, and it has to do with the technological modifications as well. And so as things have kind of evolved, like the technique, we've gone from the Evolut R platform to an Evolut Pro and Pro Plus platform, and now Evolut FX in the United States. That those later generations involve a pericardial wrap around the base of the self-expanding valve. And what that will do is, if you deploy the valve higher, like at a 3 millimeter depth versus being at 6 or worse, you're going to have more surface area contact with that wrap in the area that would be shutting down PVL, and that's specifically around the level of the leaflets, instead of taking that wrap down in the left ventricular outflow tract, where you're really not going to be mitigating paravalvular leak to a significant degree because of the wrap. And so with these higher implants, as you've presented in Optimise Pro, we've seen rates of paravalvular leak go down significantly simply because of where we're putting that wrap.
Right. And so changing gears a little bit, how does this commissural alignment help us? You talked about we need an excellent surgical-like result for our low-risk patients. So we've decreased our pacemaker rates, we've decreased the paravalvular leak rates. What is this commissural alignment? Why do I need it?
You need commissural alignment because you want to be able to plan for a patient's lifetime management and also improve hemodynamics. And so we now have good data that shows that commissural malalignment actually portends worse gradients. There's also data that shows that proximal vessel atherosclerosis would be made more aggressive with commissural malalignment. Surgeons like you align commissures on a daily basis. Why shouldn't we be doing that with our transcatheter heart valves to achieve the best hemodynamic outcomes and then lifetime management strategies, most obviously coronary reaccess, but then maybe even long-term strategies like TAV and TAV, facilitating intentional leaflet laceration, leaflet modification. All of those things are going to be very relevant to the commissural alignment discussion.
So right now today, we've been given a valve that has some new features. Been given a new delivery system, and now we have newer generations of valves coming on the market. We have newer generations of the balloon expandable, as well as new platforms coming. You talk about optimization, and a lot of it didn't have anything to do with newer technology. Most of it was newer technique. So where do we go from here? We have all of this new stuff. What do we do to optimize the individual patient's valve choice?
This is great. And it's a dynamic conversation, right? So, like, I mean, as these platforms get better and better, I'm thinking that the Venn diagram intersection for a good outcome for a patient is just going to get bigger and bigger as well. And so that's great. We can be very idiosyncratic with our valve choices. I think the more knowledge that we have about the CT planning, understanding what particular area the annulus is versus perimeter as the basis of it, but then looking more in nuance of how the aorta relates to the ventricle, be that just root angle or whether or not the length of the ascending aorta, the angulation of the ascending aorta matters with regards to predictability of deployment or ease of deployment. And then obviously looking at factors like lifetime management, seeing whether or not we can get commissural alignment with both platforms or as many platforms as we have commercially available in the next few years. This is going to be really critical for us as far as decision making. And honestly, I'd love to be in a place where there is no wrong choice. That would be ideal. So hopefully in the next few years, we're all there.
Oh, I can't agree more. I would love to have an excellent, perfect implant on every patient. And as we know, the CT scan often tells us a lot about, which patients should have which valves. So you dive into CT planning in the manuscript, and I recommend anybody who's interested in this to download the manuscript. It is excellent. But when you look at your CT and you're trying to decide between which valve for this patient, what are some of those things you're looking at? Because you and I have the luxury of having basically every platform on the shelf. And we can say, yeah, I'm going to do a Portico, or I'm going to do a Valve, or a Medtronic, or Edwards. But if you're a center that only has one valve on the shelf, or maybe two, how are you making this decision?
So if you've just got the two valves on the shelf, the way we kind of make the decision is by dissecting the CT scan so that we understand how we're going to deploy each particular platform, right? So if we're talking about the self-expanding valve, if we're talking about an Evolut platform, we're going to be looking at the perimeter of the annulus. We're going to be looking further down in the LVOT to see if the LVOT flares significantly, whether prohibitive features exist. That would sway our decision one way or the other. And then, of course, the actual size of valve that we'd be putting in and how that would potentially pretend to patient prosthesis mismatch, which would then render not just bad long-term outcomes, but shorter-term outcomes as well. And that's something on our minds, specifically between transcatheter heart valve platforms, but also when we make a decision for TAVR versus surgical AVR. A lot of our discussions revolve around what size surgical valve the patient would be receiving and whether or not root enlargement is going to be an arduous process with a smaller diameter surgical valve. Then we'll look at things like the ascending aorta, really just trying to understand exactly how the valve is going to act if it's a self-expanding platform in the aorta, whether we can expect some level of migration or movement on tab release. That's something that we've been kind of a little bit more meticulous in analyzing. And then, of course, things like calcification, calcium burden of the leaflets of the LVOT. Most reconstruction softwares are going to give you a really nice look at this and help you again decide what your management strategy is. At first, deciding between whether or not a balloon expandable versus a self-expanding valve would be equivalent in outcomes, but then also helping you plan that approach. Are you going to need to pre-dilate? What is the potential for post-dilating if you don't pre-dilate? All of those things, I think the calcium burden is going to be like a really helpful tool. And then, of course, we use it for assessment of vascular access. So I think the more you're able to manipulate your CT scan, the better of a TAVR operator you're going to be. And I think that it's just really incumbent upon every single TAVR implanter that does a high volume of valves to really try to take this out of industry's hands to a large degree and just put it in yours. That way you're making your own decisions with your patients and you're really doing a service by them just because you are handling all of their information personally.
I couldn't agree more. And that's why even as a surgeon, I am reconstructing the CTs in 3-Mincio so that I understand the small, subtle things about their anatomies, not only the watchouts, but in the annulus, but the tortuosity of the aorta, other little small features that are concerning. Because I want a surgical-like result. Now they say that, 85% of aortic stenosis in the United States is now treated with TAVR. And so, and other registries, it's up to 88%. So we really do need excellent results from the treatment. Who are you sending to surgery now?
I think that we're obviously still we still get patients where transcatheter heart valves are not really appropriate, right? So our younger patient population, where we're looking for more of a longer term outcome based on data, you're going to get better, at least data cited from the surgical valve literature at this point, just because there's been a vast experience with surgical valves. And so with our younger patients, we would be considering not just bioprosthetic valves, but when appropriate, mechanical aortic valves, mechanical mitral valves. All those are still, readily implanted at our institution. In addition to that, obviously multivalvular disease, concomitant coronary revascularization, if they have aortic root issues, all of those patients really get a hard look for surgery. And of course, if they're turned down for anything high risk or whatever, we'll try to fashion a transcatheter heart valve pathway for them. But in most isolated AVR instances, I would say the lion's share of procedures done at our institution are going to be transcatheter aortic valve replacements.
And it goes without saying that that's what the patient is wanting now, and shared decision making is taking a larger role in what treatment patients receive. So in our last few minutes, looking ahead, we said 85% of patients are getting TAVR. These younger patients are a concern. Certainly asymptomatic patients we watch. So what do we need right now? Because your manuscript's about optimization. So looking into the future, what's your perfect valve where we take to 100% of aortic stenosis is treated with a transcatheter therapy? What does that valve look like? What are we missing?
Yeah, I wish I had the magic bullet. I'll tell you kind of some of the flaws that I believe from both major commercial platforms and how they could be rectified and maybe homogenized into one single valve platform. Wouldn't that be amazing? And so obviously the large stent frame design, the long stent frame design of the Evolute is an issue. I think that it definitely would be more of a predictable deployment and something where the valve would maintain its position even upon TAVR release if the valve frame was somewhat shorter. In addition to that, there are always trepidations with regards to coronary access through that frame, and all of those need to be taken very seriously. So creating larger windows by which to engage the coronary arteries, obviously more ability to commissurally align during the transcatheter heart valve procedure. All those things are being worked out. I think that's fantastic. The strengths of that platform are the hemodynamics. And then, of course, the paravalvular leak rates and the ability of doing a recapture and a reposition. I think that all of those things are really great about that particular platform. And then with the balloon expandable valve, it really is like, what is the appropriate inflation volume for those particular valves? I think that it'll be very interesting to see the next generation of the SAPIEN platform and how maybe kind of modifying our inflation volumes may relate to better hemodynamics, may relate to lower rates of even subclinical leaflet thrombosis. I don't know. But there are tons of things that we're going to be exploring with that platform moving forward, especially as it portends to more long-term durability and hemodynamic outcomes, especially as measured by echocardiography. So I'll be very interested to see what the performance of that valve will be. So I think that some amalgamation of those two things would then, kind of lead at least all major companies to think about a transcatheter heart valve that would accentuate some of those features that I described. And then lastly, when we're thinking about long-term management of these patients, how easy is it going to be to put another transcatheter heart valve inside the TAVR valve that we currently have? And I know you've done a lot of work with this, and trying to engineer deployment strategies with the current platforms, I think is pretty interesting and something that we should all engage and do. But do we need more specific transcatheter heart valves or transcatheter heart valve engineering to actually be a TAV and TAV solution? And I think that that's an interesting area of development. And then simultaneous to that would be leaflet preservation technologies. are those something that could be readily employed to enhance the durability of an already implanted valve surgically or transcatheter? And then finally, leaflet resection modification technologies like we talked about to facilitate lifetime management with TAV and TAV. So I think that whole area of research and that whole area of technological development is kind of where I see the field going in the next 3 to 5 years. And gosh, it's going to be really an exciting time. We're very lucky to be living in the current era.
Yeah, it is really exciting, especially considering when we started, the sheath was as big as your finger, and the valves would embolize, and there were so many complications in the access and paravalvular leak and pacemakers, and we've come a long way in a decade. Your manuscript is available online. It's excellent. It is just a wealth of knowledge. I am going to give a copy to all of my fellows because I think it's essential reading about this technology and where we are in 2022 and optimizing TAVR for the best result. So Hemal, it's great to see you. Thank you so much for talking with me this morning, and thank you for your contribution to the special edition.
Thanks a lot, Kendra. It's a pleasure, and hope to collaborate again real soon.